Hola, ¿qué tal? Muy buenas tardes. Eh, Mi nombre es Martín Layú, soy profesor investigador del Instituto Nacional de Salud Pública y realmente es para mí un placer tener aquí con nosotros a la doctora Britton Travert. Britton ella es profesora en obstetricia y ginecología en la Universidad de Utah. Y también está afiliada a el Departamento de Ciencias Poblacionales de la Universidad de Utah en la Escuela de Medicina y en el en el Instituto de Cáncer Huntsman también de esa universidad. La doctora Travert tiene después de ella es epidemióloga, y también tiene una maestría en bioestadística de la Universidad de Michigan, de la Escuela de Salud Pública. Y hizo su doctorado en la universidad, en la Escuela de Salud Pública de la Universidad de Washington. La doctora Travert fue durante algún tiempo investigadora en el Instituto Nacional de Cáncer de Estados Unidos y hasta iniciar su trabajo en la Universidad de Utah. Eh, digamos, te agradezco mucho que esté aquí la doctora Britton. Nos va a hablar de cáncer de ovario. Hemos estado nosotros trabajando con ella desde hace ya casi 2 años y bueno, pues creo que es una gran oportunidad poder hablar de este cáncer que está cobrando mayor y mayor importancia en nuestro país. Ahora vamos a pasar a inglés y bueno, pues una disculpa por no poder estar de manera presencial en Cuernavaca. Tuvimos un problema logístico, pero bueno, te paso la palabra, Britton. Thanks so much for joining us today in our cancer seminar series here at the INSP. I'm really interested in hearing what you're going to present today. Thanks so much.
Great, thanks, Martine, and thanks to both you and Leticia for inviting me. Today I'm going to talk about I'm going to give an overview of ovarian cancer epidemiology and really the research that we've been doing over kind of the past 20 years to really understand etiologic heterogeneity of this tumor. Let me see here. All right. Oh, there we go. So just to give a kind of brief overview of what I plan on talking about, like I said, I'm going to talk about ovarian cancer epidemiology and the heterogeneity of established risk factor associations. I'm going to share with you a lot of the research that I've done related to the inflammatory etiology of this tumor, and then also work I've done on circulating hormones and etiologic heterogeneity. And I'll kind of present a combination of kind of standard questionnaire-based epidemiology as well as molecular studies. And so it's the traditional kind of historic view of ovarian cancer was that it was really one kind of primary tumor that developed from the ovarian surface epithelium. And then that primary kind of early tumor then differentiated into the different histologic subtypes that we know of for ovarian cancer, so serous, endometrioid, clear cell, or mucinous. But really, it's been about 20 years since Kerman and Shi have really demonstrated that there's that the origin of the ovarian cancers aren't specifically from the ovary, and that many of the ovarian cancers that we identify have really originated from the fallopian tube epithelium. And so high-grade serous cancers are the most common histologic subtype of ovarian cancer. They represent about 70% of cancers. Common mutations that are associated with them include inactivation of the BRCA genes as well as TP53. And then, like I said, they're predominantly thought to arise in the fallopian tube epithelium as precursor lesions, which we refer to as STIC, or serous tubal intraepithelial carcinoma. And then those spread to the ovary and peritoneum in terms of diagnosis and kind of further spread. The next most common subgroup I'm kind of grouping together here, clear cell and endometrioid cancers. Their common mutations are PTEN, ARID1A, PIK3CA, and they're thought to really arise from ectopic endometrial tissue and endometriosis. So really the lining of the uterus that has migrated out of the fallopian tubes and is in the pelvic cavity and is adhering to either the ovary or tubes and really highly proliferating. And then the kind of the last couple that are uncommon, more are low-grade serous and mucinous, and those are associated typically with KRAS, BRAF, and ERB2 mutations. The fallopian tube is thought to really be the origin of the low-grade serous tumors through a kind of pathway of hyperplasia, and really that kind of ovarian fallopian tube junction. And then the mucinous tumors are really thought to be germ cell with epithelial tissue. And so the 5 kind of most common ovarian cancers are high-grade serous, clear cell, endometrioid, low-grade serous, and mucinous. And so we often talk about associations for those. Because of the shifting, really this change in our understanding of ovarian cancers, there was a kind of subsequent change in the pathologist classification of the tumors. And so pathologists really started evaluating the fallopian tube fimbria, so the distal, like kind of fingertip ends of the fallopian tube. And they do this procedure called CFIM, where they basically serial section the fallopian tube fimbria and look for precursor lesions. And because they're doing this more intensive investigation of the fallopian tube, there were many tumors that were now being classified as primary tubal carcinomas, rather than calling them primary ovarian cancers as we would have in the past. And then the identification of this precursor lesion also led them to be calling the ovarian cancers primary tubal carcinomas. And so what I was able to do with with data from the North American Association of Clinical Cancer Registries, or NACER, was really to show how this shift in our understanding of where ovarian cancer originated resulted in this kind of rapid change in reporting. And so the graph here is ovarian cancer here at the top. And then you can see these very rapid increases in the reporting of primary fallopian tube cancers, which were previously called ovarian cancers, as well as a rapid increase in these kind of recognition of this precursor lesion, which in the cancer registries is imperfect. It's called fallopian tube CIS, or carcinoma in situ. And we really don't have a cancer registration code for STIC, which I think we really would benefit from. And really what this paper and kind of understanding what this really led us to understand was that we need much better standardized reporting for the precursor lesion in cancer registration. But that it also, I mean, the reason why we're not seeing a large decrease in this ovarian cancer line is because there's so many more tumors than the fallopian tube cancers. But in terms of evaluating cancers, going forward, we really include the primary fallopian tube as well as primary peritoneal cancers in our overall definition of ovarian cancer. And then because ovarian cancer is a rare disease, to be able to evaluate the different subtypes of ovarian cancer, especially the less common subtypes, it really requires work across consortia. And so I've contributed to analyses in 2 different consortia: the Ovarian Cancer Association Consortia, which I refer to as OCAC, and then the Ovarian Cancer Cohort Consortium, or OC3, which is within the U.S. National Cancer Institute's Cohort Consortium. And this is really a collection of prospective cohort study data, where OCAC was really brought together its case control studies with biospecimens to be able to look at GWAS. And then the studies that had very rich epidemiologic data, we collected that as well and have done a lot of investigation. And it really, we have really kind of demonstrated how important these consortia are, and in kind of collaborative team science, and really better understanding the etiologic heterogeneity of ovarian cancer. I don't study genetics, but I thought it was helpful when we're talking about kind of ovarian cancer epidemiology to give you a little overview of kind of family history and hereditary syndromes. As I mentioned when I was talking about the different subtypes, BRCA mutations, so BRCA1 and 2, are responsible for most inherited ovarian cancers. Those are 10 times more common among Ashkenazi Jewish in the US than the general US population. And they confer a lifetime risk of 35 to 70% for BRCA1 and 10 to 30% for BRCA2. And really, if an individual carries these mutations, it is now recommended in the US to have a risk-reducing surgery to remove the fallopian tubes and ovaries. And there's kind of a staged triage for that for people who are not kind of finished with having children. Other genetic or hereditary syndromes include HNPCC or Lynch syndrome, which include the mismatch repair markers, and that confers a lifetime risk of about 10% for ovarian cancer. And then other highly penetrant gene mutations are listed here on the slide. I will say this family history and inherited mutations account for fewer than 25% of ovarian cancers diagnosed in the US each year. So they really amount to a very small proportion of the cancers that are really included in the population-based studies. This slide very nicely summarizes the kind of wealth of information that is out there about risk factors for ovarian cancer. Like I said, family history of breast or ovarian cancer and genetic mutations. Other kind of lifestyle-based factors include use of hormone replacement therapy, endometriosis, pregnancy that increase risk. Factors that strongly decrease risk include pregnancy, use of oral contraceptives, surgical removal of the uterus, fallopian tubes, or kind of tubal ligation, which is the fallopian tube kind of cauterization for contraception. And then what we have been able to contribute in terms of the consortia is really this refinement of these risk factor associations based on histologic subtype. And so I use this heat map here with dark colors representing the stronger association, so stronger increased risk in orange and strong decreased risk in dark blue for the individual subtypes, kind of for the factors that go down the column. And so you can really see here for, let me see, I'll pick out endometriosis, which is this one that is fourth from the bottom. And so not very strong associations with high-grade serous and mucinous tumors, very strongly associated with endometrioid and clear cell tumors, which makes sense given they're kind of defined by endometriosis, and then kind of intermediate associations for low-grade serous cancers. Whereas if you look, if we look at the kind of protective factors, pregnancy is really strongly protective for all of the ovarian cancer histotypes, but most strongly for clear cell cancers. And I think the other thing you can kind of gather from this from the way this slide is presented is that there are many risk factors that aren't strongly associated with the most common subtypes, so high-grade serous cancers. And so it's really our kind of goals in understanding kind of novel risk factors for ovarian cancer really do kind of focus on trying to better understand these high-grade serous cancers. And so that's kind of where some of my research has led. Another facet of the research that I do is really to try and understand the public health impact of what we know about ovarian cancer. And so this is an example of I utilized a large prospective cohort at NCI, the NIH AARP Diet and Cancer Study. And in that study, we had more than 1,000 ovarian cancers that were diagnosed, and we were able to look at the oral contraceptive use protective association. So the overall association for OC use here, and I throughout most of my slides, I kind of represent the relative risks either in this orientation with a horizontal 95% confidence intervals or kind of flipped on the other end. But here you see that for all women, the ovarian oral contraceptive use is associated with about a 40% reduction in ovarian cancer risk. And with this analysis, we were really interested in understanding whether or not there are groups that might not benefit from oral contraceptive use. And so we really wanted to understand kind of those common cancer risk factor distributions, common like cancer risk factor stratification. So looking at whether the association varied by smoking status, alcohol use, body mass index, or physical activity. And our kind of takeaway from this is that oral contraceptive use was really associated with strong reductions in ovarian cancer risk, kind of regardless of these other cancer risk factor categorizations. Some of the recent work that we just published in JAMA actually utilized a resource that I have access to at the University of Utah called the Utah Population Database. And what this really is a large state-based linked electronic health record data with the cancer registry in Utah. And so Utah has one of the oldest cancer registries in the US. And it is part of the SEER NCI SEER-based online cancer registry. And with this, we're able to link to statewide electronic health data. And in this specific study, we utilized an exposure match design where we identified individuals with endometriosis. So we had almost 80,000 individuals with endometriosis, and then we matched them to 5 unexposed individuals without a history of endometriosis in their medical records, and then looked forward for incident ovarian cancer. And what we were able to show here, and what we were really interested in doing with this electronic health data was to be able to look at the different subtypes of endometriosis and whether or not they're associated with the different subtypes of ovarian cancer. And so we're talking about heterogeneity in both the exposure and in the outcome. And what we were able to see is that for deep infiltrating and ovarian endometriomas, we really saw kind of the strongest association for both the type 1, so we're kind of grouping together the non-high grade serous cancers, and then the high grade serous cancer, which it was an association that really wasn't well characterized in the epidemiologic data where you're asking individuals to self-report endometriosis. Instead, here we were able to have medical record diagnoses, and we were able to really finally classify the endometriosis. And so I think this is a really kind of unique example of how you can use electronic health record data to answer questions that you couldn't necessarily have answered in an epidemiologic study that didn't ask detailed information about endometriosis. And that's the case for a lot of our cohort studies because we really kind of have limited real estate in what you can ask about in a in a questionnaire that's already very lengthy. In terms of kind of the unclear cancer risk factors for ovarian cancer, many publications, the WCRF includes ovarian cancer on the list of cancers that are associated with high BMI, but the kind of absolute risk and the relative risk is really a very modest increase. So the increase is only about 10% per 5 kilogram, or less than 10% for 5 kilogram per meter squared increase in BMI. And it really is specific to, the strongest associations with BMI are for endometrioid and clear cell tumors. There's a lot of controversy about talc use. There was some modestly increased risk in early studies. And I think the kind of take home when we've been able to really kind of pool and refine these data analyses are that the very modest increased risk is really restricted to the group who haven't had a tubal ligation. So they have basically patent fallopian tubes, which makes sense because then there's really an opportunity for that talc to be able to become an exposure for the distal end of the fallopian tube and ovary. Infertility treatment or treatment for subfertility has been a very important research topic, and there's really been very limited evaluation, but the evaluations that have been done have really suggested that either the hyperovulatory meds, so the meds that really increase ovulations, or IVF are not associated with ovarian cancer risk. There was a slight elevation in risk of benign ovarian cysts or low malignant potential tumors, so LMP cancers, but that's likely surveillance bias. Those increased risks are likely due to surveillance bias. So I think the important public health message here is that the treatment for kind of subfertility or infertility really is not increasing ovarian cancer risk. And actually the kind of protective effect of pregnancy probably far outweighs any small increased risk that would be associated with these medications. And I think one of the biggest kind of unknowns in terms of ovarian cancer prevention is kind of how the switch from oral contraceptive use to the progestin-containing IUDs, which we've seen a really kind of big swing in the U.S. of a lot of women starting to use these progestin-containing IUDs because they're very effective birth control. That we don't know how at this point whether or not there will be an association. And so we're actually very hopeful that we'll see a strong reduction in ovarian cancer risk like we do with oral contraceptives. But that research question is really kind of still undefined at this point. And so kind of the key epidemiologic factors for ovarian cancer really are older age, inherited mutations, endometriosis. And then in terms of hormone therapy, it really is the estrogen-only hormone therapy that is associated with strong increased risks. And then, like I said, factors that reduce risk. And this is really despite other risk factors are pregnancy and kind of 5 or more years use of oral contraceptives. And I think the important thing that we kind of understand and that came out of the genetics work is for individuals at very high risk, so greater than 10% lifetime risk, there really is a very large kind of cancer prevention benefit from undergoing risk-reducing bilateral salpingo-oophorectomy, which is basically the removal of both the fallopian tubes and the ovaries. But I think, that recommendation really has to be couched with very early BSO is associated with increased cardiovascular disease risk long-term. And so I think there's kind of an optimal age range in which we really think about kind of the importance of these risk-reducing surgeries for people who aren't at very high lifetime risk because of their genetic factors. So to kind of segue into the work I've done and some of the work I've done in the inflammatory etiology of ovarian cancer, I'm going to kind of talk about 3 kind of mini vignettes of research that I've done. The first is work that I've done on looking at anti-inflammatory medications. So we were really interested in whether aspirin, non-aspirin NSAIDs, and Tylenol, so over-the-counter kind of pain medications, were associated with risk. And both across the Ovarian Cancer Association Consortium, so OPAC and OC3, we were able to demonstrate that very frequent use was associated with kind of strong reductions in ovarian cancer risk in the case control studies and slightly less strong in the cohort studies, but still very consistent. And so then this is from a recent publication where I brought all of the data together. And so we saw very little heterogeneity across the associations when we kind of modeled everything as identical as possible across the case control and cohort studies in terms of risk. And the overall risk reduction was about a 13% reduction in risk with frequent. So that's 6 or more aspirin tablets a week. And then in that analysis, we were able to look at associations by the 5 common histotypes, and we really saw no difference in the ability to kind of prevent cancer for prevent all of the histotypes. And then with that, kind of bringing all of that data together, again, we were very interested in trying to understand whether the association was consistent, and so that we could kind of use this information to inform public health kind of translation of our research. And in that, we were able to show that the majority of the association across the majority of ovarian cancer risk factors. So here's the overall association, that we really saw this kind of strong reduction in risk across all of the ovarian cancer risk factors that we were able to evaluate, with the exception of individuals who had a history of endometriosis. And also in that data, we were able to kind of look at the combination of multiple risk factors and really kind of show that that there was almost a 20% reduction in risk among the individuals that had 2 or more epidemiologic risk factors for ovarian cancer. And so this is kind of an important data to kind of demonstrate the public health impact of aspirin for ovarian cancer prevention. I'm not going to talk much in detail about the studies I've done on circulating inflammatory markers. I think the most consistent association that has come out of those is increased risk of ovarian cancer with high levels of C-reactive protein, which is a very generic kind of inflammatory marker and hard to kind of really pinpoint what aspect of inflammation is driving ovarian cancer risk in those studies. Then I'm going to briefly kind of present on the work I've done related to chlamydia antibodies and their association with increased risk of ovarian cancer. And so with kind of thinking about the fallopian tube etiology of ovarian cancer, we've kind of always been interested in pelvic inflammation and pelvic inflammatory disease. So pelvic inflammatory disease is typically caused by sexually transmitted infection that basically kind of migrates through the uterus and fallopian tubes and causes kind of widespread inflammation, infection, and scarring. The problem with kind of trying to study pelvic inflammatory disease in epidemiologic studies is that it's often asymptomatic. So individuals can't really accurately self-report their history of exposure. There is limited data from kind of the self-reported associations. So self-reported pelvic inflammatory disease was associated with ovarian cancer risk in early case control studies. There's been some medical record-based work done on this where they've shown almost a doubling in ovarian cancer risk in a couple of different medical record-based cohort studies. And so there you're basically getting the pelvic inflammatory disease that was able to be identified, diagnosed, and treated. And then there was some attempt early to develop biomarkers of infection or the biomarkers of sexually transmitted infections and to be able to look at this question. And so I worked with a lab in Heidelberg, Germany to develop serologic markers of prior chlamydia infection. And in this work, we really tested this in 2 study populations. So within a traditional case control study, so the Polish case control study, where the biospecimen was collected at the time of cancer diagnosis. And then we also had population-based controls. And then in a prospective study, so a nested case control study within the prostate, lung, colorectal, and ovarian cancer screening trial, which is a large U.S. screening trial for multiple screening modalities for prostate, lung, colorectal, and ovarian cancers. And so we really combined data from these 2 studies to try and understand the association. We measured a panel of infection-related markers. Specifically, we optimized this panel based on a number of markers that had been analyzed previously, and then this plasmid-encoded PGP3 protein, which in Europe is the serologic gold standard measurement of prior or current chlamydia infection. And then for comparison, we picked a couple of markers that we could measure on these panels that we knew shouldn't be associated with increased risk of ovarian cancer. So we selected HPV, specifically the 16 serovar, and then Epstein-Barr virus, which is a kind of common exposure, but that we wouldn't have expected to be associated with ovarian cancer. And so across these 2 study populations, I have the odds ratio for Poland here is the red square, and the odds ratio for PLCO is the black circle. And so we see about a doubling in ovarian cancer risk with seropositivity to PGP3 antibodies. And really, we were limited in terms of numbers, and so we were really only able to look at serous versus non-serous histology. We didn't see a strong differential association by those different kind of histologic classifications. We went into it with a hypothesis that we might see a more strong association with serous cancers given their fallopian tube origin. But we really need more data to be able to evaluate associations by the smaller subgroups of histotype. And we're actually doing that now by pooling data across a number of the prospective cohorts that have now measured these markers. And I think the kind of important, I guess you could call them negative controls, is that the other markers that we didn't think should be associated did demonstrate null association. So we really kind of felt confident that the PGP3 association was something that really, wasn't, I guess we felt like this was a very kind of robust association after kind of all of the other stuff we had looked at. And so that kind of concludes a few little vignettes of stuff I've done related to the inflammatory etiology of ovarian cancer. And really, I think what the kind of take home out of this is that for the inflammation causing ovarian cancer, I think there's kind of a couple of different pathways of inflammation we can think about, but that they really aren't strongly associated with heterogeneity in the associations across the different ovarian cancer histotypes. And so then I've done a lot of other work trying to develop circulating hormone pathways and really understanding circulating hormones and the female cancers. And so for circulating hormones and ovarian cancer risks, there's a lot of the kind of questionnaire-based epidemiologic data in terms of reproductive factors that are likely driven by a hormone association. And so longer menstrual span is associated with increased ovarian cancer risk. And that really indicates a kind of prolonged exposure to both estrogen and progestin across the lifespan, progesterone. The exogenous hormone literature, so OCs reduce risk, estrogen-only hormone therapy increases risk. And in recent studies, they've also shown that estrogen plus progestin, so the synthetic progestin, is associated with if you have the right ratio of estrogen to progestin, so basically the progestin is kind of being able to offset the increased risk with estrogen, that you really see null or kind of a slightly protective association. And then BMI, which is at least in postmenopausal women, is a fairly good proxy for high estrogen levels. That's been associated with heterogeneity in ovarian cancer outcomes, so really with the endometrioid and clear cell subtypes. And and so that's really kind of the background of why I was really interested in trying to better understand the hormone associations. And so for this project, we measured both estrogens and androgens in a nested case control study utilizing the Women's Health Initiative observational study. In this study, again, we had pre-diagnostic blood samples, and so we were able to measure the hormones far in advance of ovarian cancer diagnosis, on average 7 years. And for this study, we included almost 170 ovarian cancers and then matched controls. And so this is showing the quintile associations. And so the orientation of the odds ratio and 95% confidence intervals are kind of switched from how I have been presenting that. But I thought this was important to show really that we were seeing very strong associations for the non-serous ovarian cancers, so endometrioid, clear cell mucinous, low-grade serous really combined, that we saw really kind of this strong increased risk across all pathways of the circulating estrogens that we measured, and that the association for the serous cancers really was very null across all of the quintiles, which really suggested that estrogen is associated not with serous cancers, but with these non-serous cancers. And that association was, it is very consistent in postmenopausal women with the association that we see with BMI. I think the other kind of important aspects of this work was that we really didn't see many differential associations by the different types of estrogen, so whether they belong to the 2 or 16 pathway, which there's a lot of work from breast cancer and breast tissue that suggests that these estrogens may have differential effects on breast cancer. And we were also really interested in whether or not those associations varied by time between blood draw and diagnosis, and we didn't see strong kind of associations there. And so the kind of additional analyses that we had done really provided very little support for varying effects of estrogen metabolites on the non-serous ovarian cancer. So basically that regardless of kind of what estrogen we were looking at, they were strongly associated with the non-serous ovarian cancer subtypes. And I think then the other question I really wanted to answer with this work was whether or not androgens served as just a precursor to the estrogens in postmenopausal women, or if there were independent androgen-related associations that we could really pinpoint with this research. And so the reason why I think this is important is because of the hormone metabolism, right? And so these adrenal kind of primary androgens are in peripheral fat tissue, are basically aromatized to estradiol or estrogen. So they basically, if you have higher levels of testosterone and have high adiposity, you have high levels of estrogen because these testosterone serve as a substrate for conversion to estrogens. But there's a different pathway in terms of metabolism of these kind of adrenal androgens, and that's 5-alpha reductase, which basically creates dihydrotestosterone down through that pathway and dihydrotestosterone sulfate. So DHTS is really a reservoir for androgens in the body. But downstream of those kind of primary 5-alpha reductase androgens are these glucuronidated androgens. So androstenediol glucuronide and then androstenediol glucuronide. So 3-alpha-diol 3G and 3-alpha-diol 17G. And these markers have been shown in postmenopausal women to be a much better kind of circulating marker of high androgens in the tissue. So they're typically called a better marker of androgenic activity. And that is what this cartoon shows. And so I'll walk you through this. So in postmenopausal women, the contribution of both the adrenals and a small amount from the ovaries are basically contributing to androgen levels in circulation. And so this box on the left represents blood, and the box on the right represents the peripheral tissues that have been measured and tested. And so really these contribute to kind of a relatively small proportion of testosterone that is circulating in the blood, but that there is a much higher level of testosterone in the peripheral tissue. And so the size of the bars really here are proportional to the concentrations in either blood or peripheral tissue. And so the reason why we focused on optimizing our assay to include the downstream glucuronidated metabolites of these androgens is really that circulating levels of both testosterone and DHT are very small compared to the amount of testosterone and DHT in the peripheral tissue, but that there's really this kind of one-to-one level in terms of the amount that we measure in blood is really very reflective of the amount of androgens in peripheral tissue. And so that's really why these glucuronidated metabolites are a much better marker of peripheral kind of androgen levels, peripheral tissue androgen levels, and might be a better marker for the androgen association for ovarian cancer. And so no other studies have looked at these androgen metabolites. And so here I've again flip-flopped my axis on you guys. I'm making this really challenging, but we looked at serous and non-serous cancers. And so consistent with other studies, we had seen kind of this somewhat elevation for the proandrogens or DHEA, androstenedione, testosterone, kind of those parent androgens, for lack of a better term. And then we did see, again, this heterogeneity in the association with very strong associations for these markers of kind of peripheral androgenicity, specifically ATDG. And so this research was really kind of important in demonstrating that both androgens and estrogens are associated with the non-serous subtypes. We saw largely null associations for the serous cancers. And this is really very reflective of what we see in terms of the reproductive factors. So the reproductive factors are not strongly associated with serous cancers. They're much more strongly associated with endometrioid, clear cell, kind of those non-serous cancers. And so this kind of research on the circulating markers really kind of reflected what we were seeing with etiologic heterogeneity for the reproductive factors. I think one of the really important aspects of this is that we were really able to generate novel molecular data that allowed kind of a deep phenotypic characterization of hormones for ovarian cancer. Our assays were developed to be very highly sensitive to measure low levels in postmenopausal women. And so we really had no samples that were below the limit of assay detection. We do have really limited power to evaluate histotype associations, which it just suggests that we need to be measuring these metabolites in more nested case control studies to be able to pool and look at the associations with the rarer histotypes. But we did see really strong associations. And so fortunately, we were able to still kind of address research questions with this one study. And so that kind of is my whirlwind tour of understanding ovarian cancer epidemiology and its etiologic heterogeneity. Like I said, many established ovarian cancer risk factors vary by histotype. So we see kind of strong heterogeneity in many of the risk factor associations. We were surprised that we saw much less heterogeneity in the inflammatory exposures, but that's really been consistent across much of the inflammatory exposures that we've evaluated. So it seems to be more and more convincing. And then, like I said, the circulating hormone data really reflected the hormone-related risk factor associations, which also was, kind of consistent and not entirely surprising. And so with that, I want to thank, this work is based on so many study participants and kind of the pooling across, especially the ovarian cancer cohort consortium. There's almost 1 million women represented in some of those analyses. And so this research couldn't be done without people being willing to be study participants. And so I think we're forever in debt to those individuals. I also very much appreciate the input of my co-authors and mentors. And then I've worked with a number of fabulous fellows on a lot of these projects, as well as some really great research analysts. And so if you ever cross paths with these people, they're really outstanding and great to work with. And then I'll kind of conclude there, and I've edited my ovarian cancer epidemiology slide to kind of include the associations I talked about and presented data on. And so I am happy to answer questions. I hope that was clear, not too fast.
Thank you so much, Britton. That was great. No sé si ahorita, yo sí tengo identificado una pregunta en el chat, pero alguien de manera presencial que tenga alguna pregunta. No puedo ver yo lo que está pasando allá, pero bueno, mientras las preguntas, sean las preguntas en la sala de seminario. Aquí hay una pregunta. There's a question here. And the question has to do with, understanding why do hormone, why are there contrasting effects of HRT and OCs? Why is it that for, it's OCs, it lowers the risk, and for HRT, it increases the risk? What are the reasons?
Yeah, so I think there's a number of reasons why OCs actually reduce risk. And so they so one is oral contraceptives really, they stabilize hormone levels across the menstrual cycle instead of letting them vary. And so it's not that the individuals are getting more hormone exposure with that. It's really just that they're stabilizing. And so there's much less variation across the cycle. And I really think that the kind of cancer driving risk is related to high levels. And so with OCs, you're kind of standardizing the level across cycle. You're also with many of the hormonal contraceptives, you're either reducing or preventing ovulation. And so in those, it's like you're really reducing kind of that ovulatory damage, inflammation, and cyclic kind of exposure of the ovary and fallopian tube to that cycling ovulation. And so we've done a lot of work with lifetime ovulatory cycles, and the fewer ovulatory cycles you have, whether they're being disrupted by pregnancy or OC use or breastfeeding, really do decrease your risk of ovarian cancer. And so I think it's much more kind of stabilizing hormones, reducing ovulation, and also reducing the inflammation related to ovulation, which is why OCs are preventing ovarian cancer. On the flip side, we see once individuals have low hormone levels, that kind of reintroduction of high estrogen is associated with increased risk. And so I think there it really is that kind of hormonal exposure that is driving increased risk probably with the rarer subtype, so endometrioid clear cell. And then if you add back progestin to that estrogen, so if you're using both estrogen and progestin daily, it kind of negates that increased risk with estrogen exposure. So it's really in kind of the peri and postmenopausal women that you're adding a higher level of exogenous estrogen exposure to kind of a relatively lower background level, which is why you're seeing the increased risk there for estrogen-only hormone therapy. I hope that clarified.
Yeah.
Yeah.
Very clear. A ver, creo que hay otra pregunta. Ya, gracias. ¿Alguna otra pregunta? Okay, so I have a question. Can you talk a little bit about the mechanism for finding, the relation between IUD and ovarian cancer risk? I mean, is it the hormones? What is it? And also, my understanding is that IUDs change the uterine environment, microenvironment. So, what's the understanding on how, or can you expand a little bit on the mechanisms?
Sure. So the kind of traditional copper IUD that was, like this ubiquitous, the traditional copper IUD is very different from the current day hormone IUDs. And so we don't see an ovarian cancer association with the copper IUD. And so the copper IUD basically causes, kind of local inflammation in the uterus and really disrupts the endometrial lining, which prevents implantation of a fertilized egg. And so while they're very effective contraceptive mechanisms, they are causing kind of local inflammation. But again, that inflammation really doesn't spread beyond the uterus. And so those IUDs are not associated with an increased ovarian cancer risk or a decreased ovarian cancer risk. And so they aren't preventing kind of ovulation. And so it makes sense kind of why that traditional copper IUD that doesn't have hormones wouldn't be associated with ovarian cancer risk. I think our question, and because the progestin containing IUDs are newer, is that we are hoping, and the progestin IUD is replacing a lot of OC use. We are hopeful that we're going to see a similar reduction in risk with the hormone-containing IUD. And why we think it's local levels so pelvic levels of progestin are a benefit for both ovarian and endometrial cancer. The progestin-containing IUD is often inserted, it is often used for women who have endometrial hyperplasia or early endometrial cancers as kind of a preventive mechanism before they have a hysterectomy. And so I think we're hopeful that the hormone aspect of that hormonal IUD will provide some protection to the ovary in terms of exposure. But we don't know because they haven't been around long enough to have enough kind of prospective data to really answer that question.
Thank you very much.
Yeah.
So there's a set of questions here. So yeah, can you talk about a little bit about the relation with aspirin and the dose. And I mean, I guess the question, one of the questions is why were these individuals, using aspirin anyway? Was it because of other conditions, and at what level there? Because yeah, at what level were they using the aspirin? Was it like for cardio protection or for something else? So I'll start with that question.
Sure. That is a great question. We were very interested in, and we had hypothesized that it would have been the kind of baby aspirin would be enough. And the data is more limited, but it definitely, in terms of dose versus frequency of use, that we saw that the association was the association was robust to and really specific to frequent aspirin use. And so it's frequent and that's regardless of dose. So frequent baby aspirin use or frequent regular aspirin use. But the frequency of the exposure is the important piece for ovarian cancer prevention. We definitely looked at kind of stratification by cardiovascular disease to give us a proxy of indication for use. Most of the studies we looked at do not have information on indication for use. And that protection didn't vary based on cardiovascular disease history. So individuals who would have been taking aspirin regularly because they'd had a cardiac event. But in terms of kind of healthy lifestyle, people who take aspirin for kind of general prevention, we really couldn't answer that question.
Also, any relation with other environmental exposures, such as insecticides? I mean, is this, or anything is related to agricultural use of substances? Or
Yeah, there haven't been a lot of studies done in this area. We haven't seen really strong exposures. I know we've looked at kind of drinking water type exposures, and then data that has been come out of kind of the occupational and environmental epi space. I can say we're seeing kind of strong associations for some of the PFAS chemicals, and that's a paper that should be coming out in the next few months. Because in the PLCO, we've looked at the PFAS chemicals that are measured at CDC. I mean, there's some kind of not great NHANES research that has been done on using the kind of biomarker data from the national surveys on the endocrine disruptors with history of ovarian cancer, which is heavily skewed cancer population because of surveillance bias. But there's not a ton of work. We might have some signal for some of the PFAS exposures.
Letty, you had a question?
Yeah, my question was related to could you please tell us a little bit about what is known about exposures to endocrine disrupting chemicals and ovarian cancer?
Yeah, like I was saying, that research is very limited. The studies that have been done on the PCBs didn't show much of an association. There are other kind of, you can think about kind of the proxy literature, and so we've definitely seen phthalates being associated with endometriosis and with disruption in menstrual cycles, and so you would think that there would be some kind of potential associations with phthalates, but we really haven't seen, there haven't been any good studies out there that have measured phthalates in ovarian cancer. And then, yeah, the other kind of agricultural exposures and endocrine disruptors really haven't been looked at. Well, yeah, I think it's a very big unanswered question.
So one of the things that you presented was that, really for, the most common histotype, there's not a lot of, things that are pretty null, right?
Yeah,
Gen-
there's not a lot of modifiable risk factors. And I mean, high-grade serous cancer is what's killing ovarian cancer patients.
Could you hypothesize, what, where, I mean, where is the research going in terms of trying to understand, you know, trying to find, how to, it sounds to me there's a big gap, right? So, what is the direction?
Yeah, so inflammation, pelvic inflammation was definitely kind of the low-hanging fruit in trying to fill that gap. And so we have seen, and the inflammatory exposures seem to be fairly consistently associated with increased high-grade serous risk. And so we have been kind of able to fill the gap with those inflammatory marker associations and other inflammation-related exposures. I think thinking about tubal damage is important in terms of the etiology, but I don't think we have, unlike other locations in the body, it's hard to sample. And so really trying to understand kind of tubal inflammation, what is associated with tubal precursor lesions, it's just really hard data to collect. But I do think kind of so it's like the reproductive factors aren't strongly associated with high-grade serous cancers. And so what else is there? And I think it's a good question. I think endocrine disruptors are a great hypothesis that could be potentially associated with risk, other inflammatory markers. But yeah, we're kind of trying to answer questions in different spaces, but I don't have a good hypothesis.
Oh, because the way I think about it is, I mean, I think there's a lot of all of these indicators that inflammation, clearly, there's something there. However, you're saying that you also saw that for a biomarker CRP, which is a biomarker of low-grade inflammation. So the question is, when you say inflammatory exposures, are we thinking of things that are, just happening in the body in general, or are we talking about things that are happening locally, or a combination of both? Because it sort of feels that, when you say CRP, well, it could actually be an indication of potentially like an infection at the site, but also an infection elsewhere.
Yes. So, yeah. Which is what is kind of challenging about the circulating markers, is because it's much more kind of systemic inflammation and less the focus like pelvic inflammation. And so I think, in terms of kind of the etiology of ovarian cancer, I think it's the pelvic inflammation that is going to matter. But if pelvic inflammation is increased with systemic inflammation, then I think that also can be important. But it's really like being able to tease apart and answer that question and really say, like, we can't say that any of the circulating inflammatory markers that are associated are related to pelvic inflammation. And so, yeah, I think it's hard to disentangle.
I know we're on time, but just a final question, which, related to this, is that then what about the microbiome? I mean, maybe this is not the microbiome in the uterine environment. I mean, maybe these are not pathogens in the, in the clinical sense, but these are, bacterial. What has somebody studied how, these bacterial populations may actually, affect risk or not?
Not for ovarian cancer, no. And so I think that's another one in terms of like, what is the appropriate specimen, right? Like, ideally we want kind of pelvic, we want to be able to quantify the microbiome of the fallopian tube and the ovary, not the microbiome of the vagina and uterus, right? And so that pathway, like if you're accessing the fallopian tube, you have to come back out through the uterus and vagina, and so there's contamination in terms of the microbiome there. And so that's another. It's just a hard organ to access and a challenge in terms of trying to do that work. I've talked a lot with Emily about it. It's one of those where it's like, how do we get a good marker of kind of that, and then as soon as you perform surgery and open someone up, like you're altering their microbiome, and so then it's hard to sample there as well. So I think ultimately it's kind of the peritoneal microenvironment that is going to tell us what is driving high-grade serous cancer, but how we sample and test that, I think, is a real challenge.
Okay, thank you so much. This is
Thanks for having me.
No, this has been
Appreciate it.
I think we're all very appreciative of this. It's really great. And I'm really happy that we're starting to study ovarian cancer in the Mexican teachers cohort and its maestras. And so, hopefully we'll be able to answer some of these, outstanding questions. So thank you so much.
Yeah, absolutely. Have a great day.
Bye.
Bye.